Thank you for joining us for this webinar today. Can you move to the next slide, please, Tiffany? If you've seen our 2024 Medicaid financials release, you know that Medicaid MCOs had aggregate losses of $2.8 billion in 2024. Centene, the nation's largest Medicaid insurer, reported 2025 first half MLRs, medical loss ratios, the portion of revenue they use to pay for medical expenses, of 94.2% and 94.9% for Q2 alone for Medicaid business. By contrast, these ratios for Centene were closer to 90% in 22 and 23, and the minimum MLR for Medicaid is 85%. For smaller local and regional health plans experiencing similar high MLRs, these losses come along with risks of insolvency and market destabilization at the regional and state level. In this presentation, we'll discuss how we got here, what's next, and what MCOs can do about it. And I'll turn it over to Tiffany to introduce our panelists.
All right, thank you. Well, as you can tell, we have a great list of panelists here ready to answer your questions later in the session. But first, we'll start with some introductions. Farah Hanley is the managing principal at HMA Michigan office. Prior to her role at HMA, she served 2 years as the chief deputy for health at Michigan Department of Health and Human Services, overseeing Medicaid, behavioral health, long-term care, and the state psychiatric hospitals and centers. She also served as the senior deputy director, overseeing all financial operations for the agency. Elaine Horton is a principal based in Austin, Texas, and a leader in HMA's strategy and transformation practice. She brings deep expertise across the healthcare landscape, with prior experience at Deloitte's Strategy Consulting Group, investment banking, academic medical systems, and medical devices. Gabby Palmieri is the content development specialist at HMA, where she develops research, reports, and analysis that inform state and federal health policy and program decisions. She brings expertise in Medicaid policy and managed care. And Marcia Stein is a principal out of our Boston office. She brings to HMA a nationwide executive leadership with Medicaid Managed Care and DSNP plans in operations, finance, and strategy. And lastly, Annie Tevin-Ewing, who you heard from at the start of our webinar, is a fellow of the Society of Actuaries and serves on the task force to revise Actuarial Standard of Practice 49, Medicaid Managed Care capitation rate development, and the Health Committee of the Actuarial Standards Boards. She has served as a finance and actuarial executive at the corporate and health plan level at large Medicaid Managed Care organizations for about 10 years prior to joining Wigley. Now, just a few housekeeping things. At the end of our webinar today, you will receive a recording of the webinar as well as the slides. And as we're going throughout the presentation today, please feel free to drop your questions into the Q&A feature, and we're going to save some time at the end to get to those. So with that, I'd like to hand it back to Annie, and we'll get started.
Thanks so much, Tiffany. So, based on the background that we put together and with this multidisciplinary panel, we hope to, through this session, summarize where we are with Medicaid Managed Care financials from 2024 through 2027, contextualized against a historical background, provide an indication of the provisions, timing, and expected policy and financial impacts of OB3 and steps states may be considering to prepare for these changes, and identify opportunities for MCOs to be strategic partners with states in addressing these headwinds. Can you move to the next slide, please, Tiffany? So, financial and rate adequacy. Medicaid is unique in that rather than charging premiums to members, states pay MCO capitation rates or payments for each member based on their expected costs. CMS has a responsibility to review contracts, including the rates that states pay MCOs, and part of that responsibility includes ensuring that the rates are actuarially sound, as determined by a qualified actuary. This means an actuary engaged by the state must project expected medical expenses, administrative costs, and a margin for risk, Note that target of between 1.2 to 1.3% of revenue. And MCOs can accept the rates, advocate for higher rates through challenging actuarial soundness or other negotiation strategies, or exit the contract. Then they generally try to deliver care more efficiently than pricing to earn margins larger than those targets if they can. In the next few slides, we'll talk about how close state actuary rates were to actual experience in 2024, give a high-level update on these rate advocacy conversations for 25 and 26, and give an indication of where things may be headed in 2027. But before that, Gabby, where can our participants go to learn more about capitation rates?
Thanks, Annie. Yeah, so on HMAIS, we have a rate certification tracker, which provides state-by-state index of Medicaid Managed Care rate certifications with direct links to the source document. It's really just a great way to see assumptions on trend, acuity, and directed payments without having to comb through a bunch of different websites.
Wonderful. I really appreciate that resource. Thanks, Gabby.
Yeah.
Tiffany, can you please move to the next slide? Great. And Gabby, can you remind us where this graphic came from and how this whole webinar came about?
Yes, so HMAIS publishes annual Medicaid Managed Care financials dating back to 2012 using our S&P subscription and a proprietary model to extract, standardize, and compile the filings at the plan and parent company level. This process gives us a consistent, comparable data on metrics that matter the most. So things like member months, premium revenue, medical claims, MLR, and underwriting margin.
Yes. And you asked me to look at this as part of drafting an in-focus brief and extract themes from my work supporting managed care organizations with actuarial services, including rate advocacy. I just find the whole resource to be fascinating because it allows us to contextualize each year's results in the context of prior years. So for our audience, first, let me orient you to the graphic in the slide above. First, a concept. Underwriting margin is a margin for risk or contingency. It's what's left after managed care organizations pay all of their providers, staff, and other expenses divided by revenue. As stated in the previous slide, 1.2% to 1.3% is normally priced into rates, and plans can normally earn more or less than that based on their efficiency. So the blue line above represents the median underwriting gain across all MCOs in the financial resource Gabby mentioned, and the gray band around it is the interquartile range. So 50% of all results fell within this gray band over the years in question. So compared to that 1.2 to 1.3%, 2024 looks terrible. Negative 0.7%, not great. But it looks even worse if you compare it against the starting assumption of 2020 through 2022. So if you thought 3% was the right margin in Medicaid to begin with, negative 0.7% is even worse. And many people think that 3% is an appropriate margin for Medicaid, but that's not generally what we've seen historically. And so 2020 to 2022, things looked more favorable than previously because people in Medicaid were deferring care to avoid exposure to COVID-19. And we still saw some of that in 2021 and 2022. But to an increasing extent, as the PHE continued, the larger impact was that members who would previously have been disenrolled in Medicaid remained enrolled, and as a public health emergency measure. And many of these members who remained enrolled did not use a lot of care, which lowered the average cost for everyone.
But Annie, do you think that that should have been priced into rates?
It was to some extent, but nobody knew when that provision would go away. So different actuaries made different assumptions about whether the number of these members would stay the same, increase, or decrease. And different actuaries made different assumptions about how large of an impact this was. Ultimately, many states who didn't already have them put risk corridors into place to limit MCO profits or losses. And that is one of the reasons you see not only higher medians, but also tighter interquartile ranges in 2021 and especially 2022 compared to prior years. A risk corridor, as the name suggests, is a way of limiting gains or losses to be within a certain corridor. It's one risk mitigation mechanism that states can use to protect one or both parties in the contract. HMA and Wakely have written a lot about these mechanisms over the years, and I'd encourage you to reference the resources at the end of these materials to read more on that. One important note, though, many states removed their risk corridors after 2022, or they may have one-sided arrangements that prevent MCOs from earning too much profit, but don't restrict their losses. So that's part of the reason you see the interquartile range going so far into the negative in 2024.
So what do you think we should make of the steady deterioration of financial results between 2015 and 2019?
That is a great question. Can you please move to the next slide? Okay, so we have two charts here. The top one shows total Medicaid and CHIP enrollment from 2017 through May 2025. That huge increase you see between 2020 and 2023 was that continuous eligibility provision of the public health emergency. All the members remain enrolled rather than going through the usual process of having their eligibility checked to see if they still qualified. Then in mid-2023, states went through a process of unwinding, where they had to check the eligibility of everyone over a 12 to 15-month period. The bottom chart shows the members staged for that process in each month, and it also shows how those determinations came about. Each month a member is up to have their eligibility verified. They can be renewed, disenrolled, or held to future months to continue to review. As we began to allude to in the prior slide, there is a relationship between eligibility processes and the average cost of members in Medicaid. We can see a slow and steady reduction in enrollment between 2017 and 2020 on a national level in the same window as those deterioration in financial results prior to 2019. So the unwinding wasn't the first time we saw that relationship of enrollment losses compounded by poor results per member. Now, members can be removed from the rolls because they've been determined to be ineligible or because they did not complete processes to remain enrolled. We call the second type procedural disenrollment, and we see that as part of the bottom stacked bar. Every time a member has to prove they're eligible, introduces a new opportunity for them to be disenrolled, even if they are eligible. And the members most likely to complete these processes are the most likely to have healthcare needs, which means they're more likely to have higher costs. So you can roughly correlate increases in enrollment with looser eligibility processes and decreases with tighter processes. A lot of policy focus during the PHE was oriented toward reducing procedural disenrollment, particularly for kids and postpartum women. And that's part of the reason enrollment did not settle out at the low just prior to the pandemic or even the higher level prior to the previous Trump administration. But there are other reasons we're not back to normal from a cost perspective following the PHE and the unwinding. Can you please move to the next slide, Tiffany? Thank you. Most state actuaries expected that acuity changes would settle by mid-2024. In practice, some states ran into operational challenges that stretched this period out further, and many states experienced a gradual trickle back in of members who lost coverage and then later reapplied and regained coverage after they realized they had, sometimes serious healthcare needs. And often this resulted in additional needed care. Additionally, many states made programmatic changes that increased payments for behavioral health and home and community-based services in 2022 and 2023 in an effort to address workforce challenges and increase access to care. Those higher prices, as intended, drove greater utilization. And we're seeing other utilization trends we haven't fully unpacked well into 2025. During 2024, which coincided with the 2025 rate-setting cycle, MCO actuaries were still observing large emerging increases in costs beyond what was anticipated with acuity increases, and sharing emerging experience with state actuaries in the hopes of influencing 2025 rates. Some actuaries incorporated this emerging experience, and others didn't. Now, let's say, for example, that states are accustomed to increasing rates 2% every year, and the change from 23 to 24 above and beyond acuity increases really needed to be 4%, but they still priced in 2%. Now, if 2024 to 2025 also needs to be 4%, the necessary increase from the 2024 rates to the 2025 rates needs to be 6%, 2% to cover the shortfall from the prior year and 4% for the new increase. So this can snowball quickly and catch states and MCOs off guard. We're now having these conversations across most of our states for 2026 rates. State Medicaid agencies are bringing these needed increases to their legislatures for additional appropriations. And in some cases, what's at stake is solvency for county-based plans, nonprofit plans, and other small plans. which really account for the bulk of the losses I cited at the beginning for 2024. This is one of the reasons a large number of states are revisiting their rates in 2025 for pricing misses and recognizing that larger than usual increases may be needed for 2026. And that is where we're moving into the 2027 rate setting cycle, which will be even more challenging. And I'll pass it over to Farah to discuss our second topic, which is those state policy environment.
Thanks, Annie. I appreciate the opportunity to be here with all of you today. Wanted to talk a little bit about some of the larger Medicaid changes in HR 1, including things like the work requirements or community engagement, changes to eligibility and enrollment, and the moratorium on new or increased provider taxes. So we talk a little bit more about these in more detail. The legislation, the federal legislation that just passed this year effects on both covered lives and state finances are driven by the changes made to state-directed payments, provider taxes, and a significant shift of the Supplemental Nutrition Assistance Program, or SNAP, costs to states. So say that again, the significant effects to states' finances and to covered lives, very much on state finances, are driven by changes related to Medicaid financing and the shift of SNAP program costs to states. So, however, just talking about the first thing, let's focus on work requirements. Work requirements, community engagement, actually technically save state dollars up front. So right now, the requirement is that there are recorded 80 hours of work or qualifying activities per month to retain Medicaid coverage. And there are exclusions. They're limited to parents, caregivers for someone who has a dependent child, 13 years or younger, or as a disabled individual. There are good cause exceptions for individuals with short-term hardship related to things like medical needs and economic conditions, and states could request good faith exemptions to implementation. So what sort of impact could community engagement really have? Well, we expect substantial administrative barriers for both members and states. In the past, many states that have attempted to implement a work requirement program learned that most enrollees were already meeting the requirements, either because they were already working or they had an exemption. Thousands more reported their status through these newly built either phone or online systems. And even so, estimates showed that tens of thousands of individuals were actually going to lose their health coverage. So as an example, in Arkansas, it was found that eligible individuals were paperworked off Medicaid due to not navigating the reporting website or missing notifications, and it resulted in a loss of 18,000 people. The portal was complex, it was only accessible online and shut down overnight. Many enrollees didn't really seem to understand the new rules, and it led to this wave of inadvertent disenrollments. So previous state experiences should be a clear example of how stringent reporting requirements can cause mass overage loss without achieving the stated goal of greater workforce participation. And that disconnect between the policy intent and outcome is a critical caution as states begin to devise their strategies. And these states won't even have rules until next summer, and they're expected to use those guidelines to develop this very complex statewide program. And some states are expecting hundreds of thousands of individuals to lose coverage. So it's important to note that while there will be a significant impact to state Medicaid financing and state budgets and decisions, as I mentioned, this provision technically generates savings because individuals will lose coverage, and a state match will no longer be required for these individuals. However, we expect that there will be a number of factors that could easily offset those savings, which I'll now highlight, including significant new administrative requirements from personnel and IT. Things like the development of crosswalks of community engagement requirements with other state policies for other programs like TANF and SNAP are one of the many needs assessments that have to take place. So that's heavy resource Even more significant is the need to design, develop, and implement a new IT system infrastructure and the necessary process workflows accompanying it. Coming from state government, I can tell you that will not be a cheap effort. And evidence shows that Medicaid work and reporting requirements are confusing to enrollees. They seem complex and costly for states to implement. I read recently one former state health director who attempted to build out a work requirements program before it was stopped by a federal judge said, quote, "The sheer amount of effort and time required meant that other public health efforts had to take a back seat, and that state employees' first jobs suffered as a consequence of building out this massive program with no additional resources, where almost all the oxygen in the room was dedicated to the work requirement implementation." So I cannot underscore the enormous lift that is the implementation of Medicaid work requirements on the states. And furthermore, this legislation introduces significant changes that would really alter the landscape set by the Biden era. And this is related to reversing or limiting federal regs that require states to harmonize and simplify eligibility and enrollment procedures, and restricting in some cases the use of automatic or streamlined enrollment features, presumably making it harder for eligible individuals to be enrolled without that proactive application. So states are now going to have to also conduct Medicaid eligibility redeterminations every 6 months for expansion populations. So what's the impact? Well, if implemented, we would expect additional intense IT focus, IT investment for changes. We expect states to get ready for that increased volume of IT system capacity. We think health plans, providers, and even community-based organizations are going to need to adapt to the new requirements and these IT environments. And then also with Medicaid financing changes. So a discussion on Medicaid financing changes, the impact on state Medicaid financing is a true structural shift. And state budgets and decisions will force states to reassess healthcare priorities and will significantly limit their ability to do things like finance increased rate adjustments. For Medicaid financing, it freezes at current rates and amounts what non-expansion states can assess through provider taxes. It also makes changes to various provisions for expansion states. All of these changes end up with the implication that states will have new strategies to address to identify additional state funds, particularly in Medicaid expansion states. It's likely that we will see less states expanding Medicaid, and there will continue to be these financial pressures on providers due to that increased uncompensated care. So overall, states can begin planning for eligibility system changes, redetermination volume, and community engagement implementation, all of which require an understanding of that potential interactions of the federal Medicaid, Medicare, and marketplace policy changes. And health plans can forecast those enrollment and risk mix changes. And in addition, the plans really have to prepare for those new administrative requirements, not just related to cost sharing, and also work requirements, among other policy changes on the horizon. Consumer communications are going to need to be a focus for plans, and a very, very strong partnership and coordination with states in supporting compliance efforts to avoid federal funding recoupments.
Thanks, Farah. And I think you may have already covered this, but just in case you didn't, are there any other non-Medicaid finance provisions that will significantly impact state budgets?
There are the federal premium tax credits that subsidized premiums through the marketplace will expire at the end of 2025. While this is not specifically subsidized by states, we do expect that it'll make it, this change as well as other changes related to conditional eligibility on the marketplace will make it more difficult to enroll and re-enroll in plans, forcing people to fall off coverage. And there are significant changes to SNAP. This, I would say, is the most consequential, non-Medicaid consequential policy of all of them. So one thing is that it includes a broadening of the age range for SNAP work requirements Traditionally, able-bodied adults without dependents ages 18 to 49 were subject to work requirements. The new legislation expands that to 59. But one of the most pivotal consequential changes to states will be the decrease in the federal SNAP administrative match rate from 50 to 25%. And there's a state that I'm very close to, they alone will see a minimum of $100 million cost from the SNAP loss of federal match. Because states cost allocate their administrative expenses across all their federal grants, and they do everything in their power to maximize the drawdown against federal sources to protect the more scarce general fund sources from states. And the reduction in the federal match supporting SNAP means that caseworkers across the state and the nation will see higher costs because costs will be allocated to a federal fund source that has a lower match rate. So reduced caseloads may decrease federal funding. States are going to have to allocate more resources to program oversight and compliance on fewer federal funds. So while proponents argue that reforms promote self-sufficiency and reduce fraud, opponents have been warning that stricter requirements and reduced eligibility could increase hardship for millions of Americans.
Thanks so much. And because this all varies so much between states, Gabby, can you share some resources in HMAIS that can support MCOs as they track these changes from state to state?
Yeah, thanks, Annie. So I'm just going to call out a few of the resources we have. First, we have a quarterly Medicaid Managed Care Enrollment resource for nearly 300 health plans across 41 states and DC. This represents about 66 million members, and the resource includes plan ownership details, offerings, and distribution and market share between them. Also, we have our budget brief updates from the 2025 State of the State addresses, which summarize governor's top health and Medicaid priorities. So things like behavioral health, maternal health, workforce and housing services, and value-based payment are all included there. And then I wanted to call out our newest resource, which is the Rural Health Transformation Program Tracker. This maps each state's actions under HR1. So from RFIs to agency leads, public comment windows, and timelines with links to the official notices. This tracker just gives a quick national view of where states currently stand and what's coming next. So now I'll turn it over to Elaine and Marcia for the final section.
Wonderful. Thank you so much, Gabby. So as we think about this, our final topic is partnering for resilience and sustainability. The clients we work with, the same plans Annie mentioned that are facing that 7.7% loss compared to possibly that 3% or higher they had hoped for compared to historicals. Whether they're county plans, nonprofits, and even the for-profit plans, these leaders don't have the luxury of relying on new rates or hoping for maybe that long shot of a mid-year state amendment in the day-to-day life and work. The pressure is intensified, as Farah mentioned, when we look at the example in Arkansas, where 18,000 disenrollments happened due to previously implemented work requirements. So as I think about those two things that we've heard about so far on the webinar, there's really a heightened scrutiny and uncertainty about the future. So these leaders, maybe those of you on this webinar today, our clients, are under intense pressure from boards and executive teams asking things like, what's the plan? How do we sustain? What work streams need to start? What needs to stop? And Marcia and I are in these conversations every week, helping leaders navigate these tough trade-offs and building realistic paths forward. So for this section, we're going to break it up into two categories. The first is about administrative costs, and the second is about medical cost. And between those two sections, we're going to break it down into 3 questions that we recommend leaders like maybe yourself or others in your organization should be asking yourself. So starting first with administrative cost. Marcia, you want to take this one?
So the first question is, are you at the right starting point? For administrative costs, as an executive leader, It's probably one of the easiest and hardest places to address because it involves people. And the people who are working in the field of Medicaid are all deeply committed to the mission and are all deeply committed to helping Medicaid recipients. But with that said, under the PHE unwinding, in general, 20% of the Medicaid population was lost. And so the question you have to ask yourself first is, post PHE, is have you actually right-sized your administrative costs and your fixed costs? Because unfortunately, there's fewer members to spread fixed costs across. How do you do that? So when we work at this at Wakely and at HMA, we benchmark against the industry. We look at the administrative costs by area to see whether or not they're in alignment with what other small, medium, large size plans are experiencing. So you should start there first and make sure that you get those, that you are within the benchmarks in this area. The second question is, the question is whether or not you've right-sized, and the question is whether or not you've actually benchmarked. The question is what are your administrative efficiencies? I want to go back to what Elaine said. The issue in this arena is that you're going to have to do more with less. And so you need to start looking for efficiencies. And with that is, have you developed staffing ratios? Have you looked at it by rating category? Does your adult expansion population take more work than other types of populations? And you need to start planning for the new work requirements. The caveat I have here is that at the same time I'm talking to you about reducing your administrative load, for some states, the exact opposite is happening, and you're getting much more complex contracts. I give you an example in California. The recently implemented Medi-Cal contract in 2024 had really many more administrative requirements than previous contracts. And so there's a balancing act here of being able to work with your regulators and identify those areas of administrative efficiency so that the state can help prioritize in partnership with you what needs to be done on the admin level. The second question is, how are you preparing? So the first piece of that was what I just talked about, is really advocating with your state agency and really identifying in your contracts if there's areas that potentially were put in the contract in days when there was more money that may actually not be very efficient to do in a tight environment. And the reality is that states, as Farah stated, are grappling with the same issues as I'm talking about here, because they're having to do more with less. And they typically, what happens in that environment is states start looking down to the health plans to perform functions. But in an environment where there's limited money to go around, it's important to be an advocate with the state and being able to help them and jointly prioritize what needs to be done on an admin level. And then finally, when you're thinking about preparing for the next wave, think about what you're going to have to do to implement work requirements, which not a lot of us have experience with. And then also think about new technologies which are coming online, and particularly digital health and AI. And with that, I'll turn it over to Elaine to talk about how to prepare for a tough change.
Thanks, Marcia. So we've talked a lot about numbers. Marcia and I are talking about some tough decisions here. And the truth is especially in the administrative costs, ALR and fixed cost reduction isn't just numbers on a spreadsheet. It can mean reducing your workforce or saying no to projects that people care deeply about. Leaders have to ask, are we really preparing our teams for this kind of tough change? Are we building courage at every level to face those realities? It means hard conversations, and figuring out how we move forward, even if we have to say no to some things that we wanted to move forward. So without that, even the smartest strategies, the best actuarial analysis will stall. The human side of this change is real, and often what we recognize makes or breaks success, whether you're a small county plan, nonprofit, big plan, etc. It really takes courage and planning. And from our seat, we see folks who really take the long perspective here be most successful. We move on to MLR, and Marcia, back to you.
So I think some of the same aspects apply to MLR. The first is really data and data preparedness. And really, how well do you know your population? And have you benchmarked your utilization and your costs in various MLR buckets like inpatient and ED against both the state rates by rate cell and also nationally and regionally with small, medium, and large plans? You have to start there. You have to know where the areas are that you can impact. The issue there is that you're going to come out with a list of, and I'll just pick a number, 50 initiatives to approach. And it's the question of what's the most bang for the buck. And I would caution there, when you're looking at initiatives to prioritize from a MLR perspective, is that you be forward thinking. What's going to happen with these new HR1 provisions is that the acuity of the population that you're serving is going to change. And what is also going to happen is that the mix of folks that you are actually serving is going to change. You may see some Medicaid recipients move from adult expansion to disabled. So you're going to have an increased acuity there. And you may see the folks that actually are motivated to make sure that they maintain their Medicaid coverage under adult expansion be those that actually have medical conditions that they need to make sure are taken care of. So when you're looking at these initiatives, you need to look at them by rating category. And you also need to take a hard look at your adult expansion initiatives to see whether or not there are MLR initiatives in that category that you should put at the top so that when you see the membership mix change, you're ready for it. And then finally, I can't really emphasize enough is rate advocacy with the states. I mean, the reality is that there was a miss in the 24-25 time period. And what's happening is that as states have increased budget pressures, there's also a pressure to not increase the Medicaid rates at a pace that's as fast as it needs to be. And what's going to come into play there is real data-driven advocacy with the states, showing them why the rates need to increase more and helping them develop the case for their state legislatures to put money into Medicaid. And that is a key strategy that really all plans should be looking at. And with that, I'll turn it on over to Elaine to talk about the final question.
Great. Tiffany, do you want to press to?
Yeah, great.
And one more. Wonderful. So the final question here, are you prepared for discipline, data, and patience? Is your organization setting proper expectations on the timing of when savings may realistically be achieved from any MLR initiative? The truth is, MLR reduction is not a quick win. It demands discipline and execution, rigorous use of data, as Marcia mentioned, and patience to stay the course. Savings often take 12 months or more to materialize, which means leaders must set clear expectations early, both with their teams who are working on this and with boards and executives who are looking at those financials. Without that grounding, we've seen clients who have had their initiatives derail because of impatience or lack of ability to focus and prioritize. These initiatives take time to work. It's real people out, seeking healthcare in different ways, and whether it's utilization management, drug costs, post-acute care, different items that might fall on the top of your MLR priority list. These things do not change over, and not only do they not change overnight, but the impact to your MLR and your financials has a long lead time. So if we go to the next slide, which is our final slide of content for the presentation today before we turn it over to Q&A. At the end of the day, when it comes to these items, your organization can do anything, but not everything. So focus and prioritization is key. Success in ALR and MLR focus comes from making hard choices, aligning resources, and having the courage and discipline to see them through. And that focus is, again, what's going to separate between incremental improvement and true transformation. And if nothing else from what Annie and Farah and Marcia and I have talked through, given the changes and the realities of the rates in Medicaid, we believe that most plans are facing a situation of needing to have true transformation within their organization versus relying on incremental improvement. So this is what we encourage you to do. And let's go ahead and transition here into Q&A. And before we do that, I will flash up on the screen. This is our contact information. As Tiffany mentioned, you will get our names in this slide deck after, as well as there's a slide after this that has the list of resources. If we can pop that on the screen as well. Perfect. So here's citations and other information for further reading. So when you get the deck, make sure you go over to slide 18 for this set of links. But from here, I believe we can take down the slides and we will transition to questions. So if you just give me a moment. Wonderful. So Farah, I'll ask you to take the first question. If you know it, feel free to say it. I'm still reading them here. Okay, so can you detail further the good faith exemption for implementing work requirements? Is there a chance many states have the chance not to implement?
Sure. So a good faith exemption generally refers to allowances made for states that have attempted to comply with federal requirements, even if circumstances prevent like that full compliance. The legislation says that states are required to implement work requirements by December 31st, 2026, though they may choose to do sooner through 1115 waivers. And it permits the secretary to grant extensions until December 31st, 2028 for states that can demonstrate a good faith effort to meet the requirements. So the idea is to prevent penalizing states that are genuinely trying to meet federal standards, but face barriers beyond their control. The idea is not to give some states a free pass. So we don't expect there to be any states that will just be blanketed, allowed not to move forward. They are looking to really work closely with those states that do have barriers. And so that's why the language is in there allowing some grant extensions, but it has to be really well demonstrated that states have attempted in earnest and have just been unable to prevent full compliance by that date. Usually, from my experience of being with the state, usually it's related to IT. Can't get the IT system in place in time, workflow, that kind of thing. Those things typically hamper the implementation of these large complex programs.
Thank you, Farah. To what extent do the expected cuts to DSH payments play a role? And there's a parenthesis here of $8 billion in October 2025.
You can take this one or Farah, either way.
No, you go ahead, Annie.
My general discussion point on this is there's dish payment reductions, there's potentially pressure on directed payments towards hospitals. I think, Farah, one of the things that you and I were talking about before this is, to the extent that states have pressures on their budgets, they can really pass them through to providers. They can cut benefits. They have limited tools in their toolkit. So essentially, everything, kind of works together to put pressure on plans and providers, as a result of these cuts. So I don't think that there's a specific impact that I would necessarily want to point out for the dish, other than just continued pressure on all fronts.
Wonderful. And there's a question going back to the work requirements of how is the work requirement working in Georgia? Marcia, and then maybe Farah.
Yeah, so they've had work requirements in Georgia. I think the program was implemented in 23, and it's prospective. So you have to be able to demonstrate the fact that you are working before you can get coverage. And initially there was very limited enrollment. I think after the first 6 months of the program, there were like 600 enrollees. It was an exceptionally low number, given that I think Georgia has close to 1 million folks that were potentially eligible for adult expansion. They've loosened the requirements. I think the enrollment has increased, and I don't have a recent number, but in general, the program has not met expectations where there's a significant portion of a potential adult expansion Georgia residents actually enrolling.
Yeah, I agree with everything Marcia said, and given that I'm a love numbers person, finance and all that, I'll tell you that when we looked at it, when we saw that by the end of last year, the program cost more than $86 million, and the state said that costs increased significantly, largely because there was a 2-year delay to the program's launch. And to Marcia's point, approximately 6,500 participants, I think, enrolled in 18 months of the program. So 86 million spent, 6,500 signed up. From a state government perspective, there's a significant imbalance there. I'll say that.
Right.
Thank you. So Annie, going back to the state rate setting, if you can speak to the recent Florida rate going down, and then I have a second question after you get that one.
Right. So unfortunately, that's a pretty general question, and I can't speak to that specifically, but what I will say is that Florida Medicaid rates are very complex. They're very specific to, there's a huge number of populations, a huge number of regions. So if any one MCO's rates went down, that's probably based on, factors bigger than what we can get into in this conversation, but we'd be happy to look at it specifically, with you. And then I think I can go ahead and just go into the next question, if that's okay with you, Elaine. So do you believe states would ever alter the timeline in which they look at baseline cost trend, or do you think they do rate updates multiple times a year, given it's been so off base? That one, I think that does sort of go back to the slide that we shared about the mid-year updates, where states are already doing a mid-year update. It makes sense to go ahead and incorporate emerging trend. I think the pattern we're seeing more often than more frequent updates, which can be very costly for states to engage their actuaries, frequently, is just to be using more recent experience more frequently. And that is supported by improvements in encounter data. So I think generally we're supportive of that, and it does help without increasing burdens on states to do updates multiple times per year.
Annie, can I just add something? I'm going to do a pitch in here for rate advocacy with the states. In many of the states, the health plans have joined together to actually advocate to the state. They've employed Wakely, actually works with the state associations, and my past experiences, that's been very effective. So I would definitely put a plug in there for that. It's important that the plans articulate to the state that the rates are not adequate and be specific about where the inadequacies exist, so that way there is a better chance, I think, of getting a response.
Agree. And I would say that most of the years that I've been working in this space, which is my primary area of practice for the last 10, 12 years, it has been a methodology issue, or, you know, a technical issue with the rate development that was a problem. I would say in the most recent couple of years that it has been emerging experience. You know, we don't know exactly what it is, but we're seeing emerging experience. If you're looking at old information, it's old information. It needs to be, you need to supplement it with more recent, you know, emerging trends to really understand what's going on. And you're right, Marcia, if you just share with the state, you know, here's our emerging experience, it's very easy for the state to just say, well, you know, you're inefficient. It's okay with everybody else is okay. But when you aggregate all that experience together and then share it with them, that issue goes away. But I also don't want to dismiss the responsibility of the plans to manage those cost trends. That's what they're being hired to do. So back to your points, you know, Marcia and Elaine, about, you know, yes, 1, 2, 3 years in a row, we can say, look, emerging trends. And then at some point you have to say, well, how are we going to work on this together? And I don't want to say that we're going to, you know, limit access to care, but, you know, everything has a cost, and we all need to be realistic about, you know, honing in on how we can make sure that the program delivers on its core promises, you know, and those costs can be reined in to the extent that they're increasing, you know, more than the program will support.
I think that, you know, to go to your point, Annie, and to make sure we get to the other questions, one of the underlying trends on the MLR is that post-pandemic utilization increased and it has stayed increased. And so when I talked about benchmarking, there is a new normal. And so when you're thinking about MLR plans, it's really going back and trying to figuring out where the costs have increased, looking and benchmarking to figure out where you have the ability to find efficiencies.
That's right. So the utilization increases, and I spoke to this a little bit, and then you can see more in the financial and the resources we link to. But some of the categories where we saw largest increases are exactly the categories that were identified as needing payment rate increases due to limitations to access to care. So behavioral health, home and community-based services. If you look at the 50 state Medicaid director survey that HMA does in partnership with Kaiser Family Foundation, you know, those were the priorities that medical directors identified, you know, the last couple of years. We're going to pay these providers more to deliver these services because of limitations in access to care. Well, what happens when you do that? You know, access to care improves, utilization increases. And we see that in those increases in those categories, but we're also seeing other categories that are harder for us to understand what they are, and we have to get our hands around those.
So I think that somewhat answers one question about what needs to happen for behavioral health, home health trend to finally decelerate, you know, any line of sight to drivers of deceleration in the next 12 to 24 months. You know, I think there's a lot of different data and ways to answer that question, but one way is maybe it won't decelerate, right? The past rates were deflated due to lack of access, and so readjusting the baseline there. And pharma was also brought up there as something to look into. And I think that also comes together with Marcia's point of the new normal of those line items. There's some questions in here from our audience who aren't from the MCO side as much, but more the provider side. So advice for IPAs, you know, physician groups who are primarily in Medicaid value-based payment arrangements. What can we do to prepare for the loss and attribution? Will there be any shared savings in this environment? You know, similarly, is there still an opportunity to pursue value-added services that improve outcomes for members that can count towards the MLR quality improvement activities? What can those folks who are serving those members from the providers from this? Farah, do you want to start?
Sorry, I'm Was trying to get off of mute. Yeah, I think providers and plans, honestly, I would lump them together. I think there's a real opportunity here to lead and to support. I mean, I'm coming from the state perspective. The states are really up against some real challenges. It's not just administrative, it's financial, it's operational, and getting smart people in a room to help develop strategy, and then from strategy, the tactics and the decisions is something states are really looking for. They're going to want help. They're going to want that insight. And I think plans and providers have an opportunity here to really lean in and provide some leadership and some collaboration. So when I think about IPAs in general, I really think that, and I understand, they're in these value-based contracts and these arrangements. This is where they talk about the success of those arrangements. This is where they lean in and say, here's where we're doing really well. The outcomes are looking good. The metrics are really telling us that these outcomes are demonstrating success. That's where I think that there's an opportunity there for the providers and the plans. And I would say that for a lot of the answers to the questions as it relates to states, for example, the reintroduction of the risk corridors was one of the questions. As headwinds persist for Medicaid managed care organizations, will states do this? I do think states are going to do that. I think I know of a couple that already have them on their list because, states can only go to rates, services, and populations. And typically states are like, hey, we'll just go to rates, because we don't want to cut people off and we don't want to cut benefits. I'm telling you, they're going to all of them. They're going to go to all of them. They got them all on their list. And it's just a real, like I said earlier, structural shift. So I think I went a little broad there, Elaine, but just wanted to catch that.
No, I think that's great. And it looks like we do have quite a bit of questions on, work requirements, and if there's a perspective between this panel about if the costs will shift to managed care plans and implementing, if there's need for new technology in terms of tracking these eligibility requirements. Would anyone like to give a perspective on that?
I'll pop in here for a second because I went to the Medicaid
Wonderful.
Health Plans of America last week, and this was clearly a topic, and there were a lot of vendors there. I think, what I heard was really two avenues. One is engagement with community-based organizations, because the general feeling is that most folks, and I think this is borne out in Arkansas, don't necessarily understand what is actually happening, and that the need for education on multiple levels, from CBOs to providers to state Medicaid agencies, is really critical. The second thing I heard and saw were a lot of vendors really working to get a technology solution. So I think that we're going to see a lot as more information comes out about these work requirements. We'll see a lot of technology solutions to try to enable folks to get either redetermined or also, to deal with the work requirements. So with that, Farah, you must have some pretty deep insights about what you think about this.
Yeah, I mean, I think generally states, like I said, they're just going to go anywhere they can to try to come up with some kind of solution. And they're going to need some real strong collaboration. They're going to need some real strong leadership. This is something that it's such a big lift. It's very, very complex. And I think that managed care plans have a real ability to demonstrate that they can provide solutions, that they can come up with options, that they're the boots on the ground. And I think when they do that, it's just going to be, really mutually beneficial.
Thank you all for these questions, and thank you, Marcia, Farah, Annie, for addressing them. Tiffany, is there anything you want to say before we close out?
I just would like to remind everyone that we will be sending the slides and the recording of this session after the webinar. and want to thank you for joining us today. And with that, I think we are good to go. Thanks, everyone. Enjoy your day.
Thank you.
Thank you.